I wanted to touch on something that is important for our day-to-day practice, and we see this in our behavioral healthcare system. The rules are changing. If you don't have to have your charts audited by anybody, then it doesn't really matter. You see a patient, you say patient's doing well, one-liner, and that's about enough. Nobody's ever going to have a look. However, like the rest of us, if you have to have other people convinced that you actually did your job or your team did your job or their job, then obviously it's important that we keep up with the times. All of sovereign health facilities are accredited by the Joint Commission. And the Joint Commission's behavioral health guidelines or standards are changing from the 1st of January 2018. And they're going to include measurement-based care as one of their criteria. It's important that we understand what it means and why it's there. And so I thought I'd talk briefly about it so that those of you who are impacted by it would be able to see how you already do these things, or you might want to start thinking about it. As we know, a lot of people are dying every day because of opioid problems in this country. And we need to ensure that we are responsive to this need and to this crisis. How do we respond to this crisis? It is really a moral test as much as an academic as well as a clinical test. And these are quotes from this and the next slide, quotes from our Surgeon General. I'm sure you've read that extensive report, page by page. Coming to measurement-based care, which is what I'm going to spend the next few minutes on. You'll hear this more and more as time goes on in the next few years. It's the philosophy and the system of providing care, and is informed by outcomes reported by patients. There are companies like Optum, part of United Behavioral Health, that have already included this in some of their assessments and measurements for people that are in network. For people that are out of network, we still have the option of including that, but not if you're accredited by the Joint Commission as Sovereign Health is. From 2018, this is going to become mandatory. It's defined as the practice of basing clinical care on patient or client data that's collected throughout treatment. So how do we define it further? The issue is very simple, that we don't have any standards that we are adhering to in treatment. And the need arises now for having some basic standards which says, let's have some symptom rating scales. We know that we have that for clinical trials. Every clinical trial has symptom rating scales, but that takes ages. And you can't spend 4 or 5 hours per patient as you do in a clinical trial. And most of you that have done clinical trials know this. How do you incorporate that into your usual clinical practice and yet make sure that you're complying, if you like, or using measurement-based care? I think that's the challenge that we have. When you have a large number of patients that you are dealing with, how do you still employ measurement-based care? So administering symptom rating scales that drive clinical decision-making. And the data shows that I think about 18% of psychiatrists and 11% of psychologists are using any form of monitoring. If you think of this is intuitive. If we don't have a blood pressure equivalent, a blood sugar equivalent that we measure our work and the progress of patients by. So if you think that the patient is improving or the patient thinks they are improving, the question is by how much? And so this is not a new thing, it's intuitive. How do you then incorporate this into your day-to-day practice? We need to have a demonstrated excellence in the techniques that we're using. And there should be, we all know that there needs to be a therapeutic alliance. All this is fine. How do you succeed? One of the most important things is in measurement-based care that the Joint Commission and other authorities are talking about is incorporating patient feedback into treatment. and frequently getting patient feedback and modulating treatment based on patient feedback. This doesn't take very long. And there are 4 domains that are important: symptoms, functioning and satisfaction with life, readiness to change, and session feedback, and working alliance. Working alliance is a therapeutic alliance. And it's interesting that studies in therapeutic alliance has shown that it doesn't matter what kind of degree you have. You could be an MD, you could be a substance abuse counselor. It doesn't matter in the hierarchy of things. The therapeutic alliance is independent of the kind of qualification that you have. And it makes intuitive sense, because when a patient is asked for feedback, they don't necessarily think of the degree that the person treating them has. They think of how warm that relationship has been, and are they able to trust that person. So when patients ask for feedback, it empowers them. It also allows them to understand their disease process. And having people as part of the therapeutic process, we found is extremely important in terms of their long-term follow-up as well. So this study shows us some data where you can see very clearly that the outcome, this is the Hamilton Depression Rating Scale. It shows that if you use measurement-based care, that there, on almost every single criteria, you have lower depression scores. For those people that use measurement-based criteria and the system of care, there's greater symptom remission and much better outcome in these patients with depression. So what are the benefits? The benefits are that it provides insight into treatment progress. You can see, are you making great progress? Are you not making any progress? And the same with your clinical team. So what about ongoing treatment targets and sharing those targets with the patient or your client, or looking at whether symptoms are really going down, and having some kind of empirical measure of doing this, and as a framework of guiding treatment. It has both, as I said, theoretical as well as diagnostic, transdiagnostic relevance. It doesn't matter what patients you treat. You might treat patients with a primary of mental illness with concomitant substance abuse, or you might have a population where you have substance abuse with comorbidity and a dual diagnosis, and a severe dual diagnosis population like we treat. And we treat actually both types of population, as we are licensed for both mental health as well as addiction in most of the states that we operate. So it provides us with highlights into how the patient's operating. Well, what does it actually measure? It measures patients' symptoms, their ability to function and their satisfaction with life, and their readiness to change. That's a really important piece in terms of readiness to change. You can look at where they are in that whole graph, if you like, of readiness to change. And then it furnishes feedback about the therapy sessions and the relationship with the therapist. Research shows that adding measurement-based care to routine care provides notable improvements, and I've shown you that published data. And we've seen this also in our adolescent facilities. And the one in San Diego, we've shown that with scales that are appropriate for adolescents, you can also show improvement. And in some cases, when there are no improvement, you have a case conference, you figure out why this is the case. Rather than just depending on the therapist to get this up, you have some empirical data as the head of the clinic or as somebody who's a team lead to see how your patients are doing in general. And it doesn't have to be that complicated, unlike a clinical trial. And for providers, and those of you that are answerable to any providers, or even as an internal quality control system, if you're in a healthcare system that doesn't depend on outside payers, which is a rare occurrence nowadays, you can show how well you're doing, and then have some metrics as to what you might be able to show people outside, that these are. People talk about outcome and relapse a year down the line. I have no control how my patient's going to do after I discharge this patient. Most of the time, they're not even in contact or they have lost contact, even though we try to follow them up. but you have much more control over how your treatment is doing. And I think it is imperative now that we start measuring how we are doing. We need to have the blood pressure equivalent, the blood sugar equivalent of what we do in treatment. So you can at least say my treatment or our team's treatment is this good or this bad, as the case may be, and then you change that accordingly. So it can streamline the assessment process, and is driven by data. And I think that's what is required. We need to be driven by data rather than our impression, our gut feeling of whether the patient is improving or not. And we've seen patients in our system provide feedback and say that there's a much greater sense of involvement. Our AMA rates go down because they feel much more involved in what they are doing. And the chance of having to rate their symptoms, they gain a better understanding. We're telling them, look, this is not improving. We need to work on these things. That's why you need to attend these kind of sessions, or when we have cognitive problems, cognitive remediation or cognitive enhancement therapy, even with patients with schizophrenia or with addiction, that we might want to do. So lack of progress. This is something, again, that is important for us. We can see what we might want to do with patients that have lack of progress. Or maybe we need to refer them somewhere because they are recalcitrant or they're not suitable for our system of care. And they streamline the assessment process. And as I said, we found feedback to be really important. There are financial implications of this from an institutional point of view in terms, as I said, of quality control, talking to providers. In terms of your advertising sometimes, you have real data now as to how your patients are doing or not doing. And you can make some data-based decisions rather than getting people around the room and saying, well, how do you think we're doing in our treatment? And as I mentioned previously, these are the 4 domains that you need to think of. If nothing else, if you remember these 4 domains, you look at that and say, well, we need to be measuring, have some measure of symptoms, some measure of functioning and satisfaction with life, some measure of readiness to change, and then session feedback. How did the patient, what was the patient's satisfaction or not with this session, as well as the therapeutic, working therapeutic alliance. In terms of symptoms, you can collect symptoms through a variety of means. People have used the PHQ-9. The PHQ-9 is a free instrument, as I've shown here, the GAD-7. The phobia rating scales, these are scales that, these are just examples of some scales. There are scales that you don't have to pay publishers for. They are free, they're free of cost, and you can use them in your clinical practice. Functioning and satisfaction with life, the SAS, as well as the people sometimes have used the quality of life inventory, which is a 5-minute scale. Again, these are not taking you very long, and you can have ancillary staff that you might have in your practice do it, or you might do it yourself, just to get some data in terms of how you're doing with your patients. Readiness to change, as you know, is one of the most important things in the addiction field, especially looking at where patients are in that curve. And explaining it to them. We found that explaining this to them and getting them some insight about readiness to change and using change scales has been really, the questionnaires along those lines has been really helpful in people getting some insight as to, well, I came into treatment because my spouse, my loved one, my son, my daughter wanted me to come into treatment. Well, how ready are you to change? How ready are you? The same with people. Well, I was hearing voices and my mother decided that I should be in treatment. Well, what about you? So possibly the most important variable is this session feedback and working alliance. Scott Miller and his colleagues have done a lot of work on this in terms of the therapeutic alliance and the 2 rating scales that we use. And they're really simple and 1 page each, and they're almost like it, and a visual analog scales actually, the outcome rating scale and the session rating scale. And I would urge you to look at these as you improve your clinical practice. The outcome rating scale measures 3 dimensions: personal and symptomatic distress, interpersonal well-being, and a social role. And the session rating scale talks really or measures the therapeutic alliance that the patient has with the therapist. And we found that using feedback from that, you can modulate and you can figure out who is a good therapist and who is not. And you'd be surprised that there is, as I mentioned earlier, there's absolutely no correlation with the degree that somebody has. And the working alliance inventory the same way. So these are short scales. They take a few minutes each. They are not long like the clinical trial scales, but they also are very useful in modulating treatment, in changing, in course correcting, in making sure that you're also keeping your patient aligned and decreasing the AMA, the ACA, however we want to call it, the rates of people not engaging in treatment. So, and these are the points, I won't read them out, in terms of what it takes to get a patient to be successful in treatment. But listening to the patient, it seems pretty obvious. These are issues that you're taught well early in your careers. What is not working? As I mentioned, 18% of psychiatrists and 11% of psychologists currently use any kind of measurement. So as we go through, as we become more accountable in terms of how we're doing, it's important that we adopt this. And there's a lot of literature now to show that this is the way to go. And patients also, the outcome of patients that have participated in measurement-based care is much better. So I think it's imperative that we rethink how we are doing our clinical practice and the teams that you lead and what you might want to do. So it's not about what therapy necessarily works. You might have a different or a personal model that works, and whatever model that is, it doesn't really matter in a way, because this eclipses all of that. This is almost like an umbrella issue. And so whatever model of treatment you have, whether you practice mainly medication-assisted, mainly psychotherapeutic, it doesn't really matter. Based on all of that, the most important thing is, am I measuring how well I'm doing? Am I able to say, this is how our patients are improving or not improving? Only by doing this can we be at par. We have got parity as far as mental health and substance abuse is concerned. But the question we've got to ask ourselves, are we at par? Do we have the measurements? A surgeon's outcome measures are looked at by looking at the infection rates and how long a person is in hospital. How would we have the equivalent as teams of mental health addiction specialists, whether going from psychiatrists to the care workers? What can we do to ensure that we are held accountable and to the same standard, that we are at par from a clinical standpoint? Thank you.